next keynote speaker is Dr. Curtis Langtloz. Langtloz is Professor of Radiology, Medicine, and Biomedical Data Science, and Senior Associate Vice Provost for Research at Stanford University. A distinguished physician scientist, Dr. Langtloz did all his degrees at Stanford University with an MD and PhD in medical information science. He completed postgraduate medical training at the Hospital of the University of Pennsylvania, specializing in radiology. Dr. Langtloz is a renowned pioneer in medical imaging informatics and AI. His NIH-funded research laboratory has developed groundbreaking machine learning techniques designed to enhance the accuracy and efficiency of radiologic interpretations. At Stanford, he serves as the director of the Center for Artificial Intelligence in Medicine and Imaging, AI/MI, leading interdisciplinary collaboration among over 200 faculty members to advance AI innovation for improved clinical care. Dr. Langtloz is a fellow of both the American Institute for Medical and Biological Engineering and the Society for Imaging Informatics in Medicine. Throughout his career, he has been recognized extensively, receiving awards such as the Radiology Alliance for Health Services Research Career Achievement Award, and he's widely published with numerous influential peer-reviewed articles. In addition to his academic and research endeavors, Dr. Langtloz has served on numerous editorial boards, including Radiology and the Journal of Biomedical Informatics, and held leadership positions in major professional societies. He is currently the president of the Radiological Society of North America, RSNA. His work exemplifies commitment to harnessing AI technology to advance clinical care and improve patient outcomes. Please welcome Dr. Langtloz.
Well, thank you, Jason, for that kind introduction. It's a pleasure to be here in Taiwan. This is my second visit. It's a beautiful country. I want to thank Professor Huang for convening us these past 2 days. I've been really inspired by all of the presentations, and particularly by Professor Huang's discussion yesterday about how humanistic medicine really isn't the opposite of high-tech medicine. That in some ways, high-tech medicine can help us practice more humanistic medicine. And I think that'll be a theme today. AI is really going to revolutionize the way that we care for our patients. And so at the same time, we're going to have to think about how we want to change what we teach to our clinical learners and how we teach to our clinical learners and how AI will affect both of those. Part of my goal today is to give the clinicians in the audience one more step on your journey to learning about AI, learning about a little bit about how it works, so that you can understand when it might be leading you in the wrong direction or in the right direction. Before I get started, I have one disclosure, which is that I do advise and hold shares in several radiology AI companies. I won't mention any of them today. Let's get started, and I want to start with a clinical case. So this is a 83-year-old woman, and she's had her aortic valve replaced. She occasionally gets short of breath. She came and had this chest x-ray about 18 months ago. It was read as normal. And then she recently came back and had this chest x-ray. Now you can see she has a large mass in the right chest. And if you look back at the prior study, you can see partially behind the rib and in among the vessels of the right lung, there's a small mass that was missed on that day. And I show this case because the literature tells us that 3 to 4% of diagnostic imaging interpretations contain clinically significant errors. And so all of us who build these kind of AI tools feel a special obligation to help with these kinds of detection problems and errors. Okay, so our agenda for today, we're going to talk about AI. I want to start by talking about why is everyone so excited about AI right now? There have been many waves of AI, and this one clearly is different. Then I'll describe some of the things that are happening in the research lab and some of the new applications that we're seeing and the ways in which AI will affect the practice of medicine, particularly imaging. Then, of course, we have to talk about ChatGPT and language models and how that will affect us. And then finally, I want to give you a sense for the challenges that we see in the research lab and in implementing these technologies for clinical care. Okay, so let's get started. I want to go way back into history. I want to tell you a story about AI. So this is the earliest neural network. This was published in 1958. It's called the perceptron. Simple mathematics. It's some inputs, a sum of products, and an output, the other side, that makes a decision. I'm not quite that old, but this is my undergraduate thesis from 1981 about neural networks, and I concluded that they didn't work. And actually, I was not alone. There were many people, most people at the time said they didn't work. Why? We did not have enough data. We did not have enough computing power to develop the right accurate neural networks. The thing that's changed it recently is these massive data sets and the computing. And this data set is what really revolutionized AI. So it's called ImageNet, was assembled by my Stanford colleague, Fei-Fei Li. Contains 14 million images scraped from the internet. Each one contains a dominant object in the middle. So on the left there, you see the garden spider. And it's a challenging visual recognition task. So you see different backgrounds, different orientations. There are over 20,000 different types of things in this database, 800 types of birds, 900 types of trees, musical instruments, and so forth. Each year, the computer scientists held a competition to see whose algorithm could be most accurate at identifying the objects in these images. And I'm going to show you the error rates of those algorithms over time. In 2010, the error rates were over 25%. Same in 2011. That's using old-style AI. In 2012 was the first time these modern neural networks were used. It was won by a team from the University of Toronto, led by Jeff Hinton, who became head of AI at Google. 2013, everyone was using these networks. It was won by a team at NYU, led by Jan LeCun, who currently leads AI at Meta. Then the next year was won by Google, then was won by Microsoft, then was won by two teams from Asia. And you can see the error rates have dropped dramatically and in fact have flattened out. And at that point, one of Fei-Fei's students said, I wonder how humans would do with this task. And so he studied up on all the different types of dogs and cats and spiders, and his error rate was about 5%. So we're getting human-level performance, the error rates are flattening out, and they said, this task is too easy. We need a harder task to test our algorithms now. And so they decided on something that was then called automated captioning. So now we have a picture that has multiple objects, and all of the boxes and all of the text here is generated automatically by AI. Bottle of water, cup of coffee, blade of fruit. When I saw that, I saw Fei-Fei present this slide at the 50th anniversary of our computer science department at Stanford in 2015, and I said, that's what I do. I look at pictures, I find things, and I describe them in text. And so I think everyone realized this is a very powerful technology when it's applied to medicine and specifically for medical imaging. What are we really talking about is neural networks that learn from data. And so we can pass examples. Here we have a malignant breast lesion, a benign breast lesion. We pass multiple examples of those through a neural network. I like this schematic because you see the Greek letters there. It's just mathematics. It's a bunch of matrix operations. It's just math. And at the other side, we get an answer. Is it benign? Is it malignant? And based on whether the algorithm gets the answer right or wrong, the computer scientists have figured out how to adjust the parameters in the model a little bit to make it more likely it will get the answer right the next time. And so over billions and billions of iterations, these networks get to be excellent at what they do. What's really happening under the hood is an image is really a matrix of pixels, and each pixel has an intensity level, a number that represents how bright that pixel is. And those matrix operations, the neural network, really distills that information down into a vector, a single list of numbers. This isn't exactly what's happening, but the way that I like to think about it is that each number represents some important feature in that image. What's the most diagnostically important information in that image? So one might be representing the degree of spiculation. It might be representing the borders, or whether there's microcalcification. In fact, the computer has its own way of representing that information in this vector, but that's exactly what the neural network does. Then we use regression. So we put a coefficient in front of each of those numbers, and we do a sum of products, and out the other side we get a single number. We scale it from 0 to 1, and we make a threshold and say if it's greater than 0.7, it's a positive. If it's less than 0.7, it's a negative, whatever calibration we want. And so that's fundamentally how a neural network classifies a medical image. Nothing more than just a bunch of mathematics. And in fact, we now have, because of this appealing technology and the way that it works, we have in the United States a real industry. So this shows the number of algorithms, they're called software as a medical device, that have been cleared by our Food and Drug Administration over time. This is partial data from 2023. We now have over 1,000 of these algorithms that have been cleared by the FDA. And if you look at what specialties are targeted by those, over 3/4 of those software algorithms are radiology algorithms. So that's why I think it's fitting today that we're going to focus a little on radiology, because we're a little further along in the implementation, the business aspects, all the aspects of implementing AI in medicine. And in fact, we do have an industry. So I just came back from our national RSNA meeting, as Jason mentioned. And in fact, we have over 100 companies exhibiting there who are selling AI products to radiologists to help with their practice. So it really is an industry in our specialty. Why is it that radiology has led? Number one is about data. So we have more data than many other specialties. At Stanford Hospital, we have 1.7 petabytes. So megabyte, gigabyte, terabyte, petabyte, 1,000. So 1.7 petabytes of radiology data. We have 3 petabytes of pathology, digital pathology data. And these neural nets, as we just saw, are very good at processing images. And I would like to think that our imaging data is a little more objective than a symptom that a patient has that's described to a physician. The physician writes it in the chart, and then we need to process that language and understand what that means. Instead, we're imparting energy to some 3-dimensional space in the body. We're understanding what tissue, what's happening with the tissue at that spot, and that's perhaps a little more objective. Okay, so that's why everyone is excited about AI right now, and that's a little bit about how it works. Now I'd like to give you some examples of AI algorithms and the direction that I think things are taking. Before I do that, just want to thank, this is all of the over 200 faculty in our centers, the Center for AI Medicine and Imaging at Stanford, and also the individuals in my own lab who have worked on some of these problems, particularly the language modeling problems that I'll show you later. We have algorithms being built from head to toe and for different imaging modalities. And I want to describe how they affect radiology practice, thinking about it from the cycle of an image, from the time that it's ordered to the time the result comes back, and maybe you think about ordering another test. So first is test selection. So AI can help the clinician who's requesting a test decide what test is best to order by indicating how likely it will be positive. There are now algorithms that can help with image reconstruction. So we can use less radiation dose, less contrast, less time in the MR scanner, and still get a similar quality image that still is diagnostic quality. So we get less expensive devices. Quality control. So we have a technologist who's sitting at the console of an MRI machine or a CT machine. Perhaps the patient is moving or breathing and the images aren't of diagnostic quality. That technologist may not notice that. I might notice it a couple of hours later when I'm interpreting that study. Now the patient's already on their way home, maybe the contrast is excreted, it's a problem for everyone. So this is a way that we can help that technologist understand whether those images are adequate quality and potentially repeat it right then and there, save the patient from coming back. Triage. So if I am on call on a Saturday, I might come in, there would be over 100 cases from the ICU waiting for me to interpret chest x-rays. Some of those cases have some important information that needs to be handled right away. maybe a pneumothorax, maybe a new pneumonia that needs to be treated. I would like to know which of the 10 of those 100 cases are more likely to be positive, so I can read them first. So these algorithms can triage those cases. And then computer-aided detection. So this is exactly the kind of algorithm that can help with that nodule that was missed that I showed you at the beginning of the talk. Classification. So many radiologists now are specialized. If I'm a chest radiologist, I may not be in my comfort zone if I see a lesion in the bone, in the humerus, on the corner of the image. I'm lucky I have bone radiologists right down the hall who are world experts, but not everyone has that. So it would be wonderful to have an AI algorithm that can give me a differential diagnosis for that lesion. And then reporting, communicating the right information at the right time when it needs to be communicated. So all throughout the life cycle, we have algorithms that can apply. Okay, so here's an example. This comes from the lab of one of our neuroradiologists, Greg Zaharchuk. We do a short 10% dose of contrast for some of our perfusion studies just to look at the transit time of the contrast through the cardiovascular system. And so he took a look, could he build an AI algorithm that could predict what the full contrast dose looks like from the 10% dose. And so he created this synthetic image, and then to the right there you see the actual 100% dose. And in the paper that's cited there, you see not just evidence that they look the same, but actually you can make the same diagnoses with these images. So a very powerful concept, which helps us with smaller devices, shorter imaging times, lower contrast dose, lower radiation dose. These are very powerful tools now, being actively used in radiology. This is from my colleague Bao Do, who's at our Palo Alto VA Veterans Administration Hospital. He's developed algorithms that can find the most common abnormalities on musculoskeletal radiographs. So here the algorithm automatically finds that there's some arthritis in the right hip, can detect the presence of a hip prosthesis in the left hip, and then fills that information into a template. So it essentially drafts the report automatically. I tell our residents this is like an e-resident. And that's, I don't think we would use this, we could talk about this later, about the educational role, but I don't think we would replace residents, but 2/3 of the country, in the US, don't work with residents, so it would be a very helpful productivity advantage and build more consistent and accurate reports. This is a really interesting concept, which is opportunistic screening. So on the left, we have a coronary CT. This is gated to the heart, so it's imaged at the same point in the heartbeat, and as a consequence, the heart is frozen, and you can see the 2 white dots, which are calcium in the coronary arteries. And that's a marker of risk. Someone with that kind of calcium should be on a cholesterol-lowering drug, a statin. We do about 2 million of those a year in the United States. On the right, we have a routine CT on the same patient. Might have been done for pneumonia, for a nodule follow-up, or for trauma, for example. And because the heart is not gated in those routine studies, you can see the calcium in the arteries is smudged. It's blurred. We thought, but could we build an AI algorithm that could detect that calcium even though it's blurred? And we did that. And we published it in this Nature publication showing that it was accurate. And so we have the opportunity there to find 18 million people in the United States who have heart disease who don't know it. And then we wanted to show that this could have an effect on patients, so we did a randomized prospective trial where half the patients got the usual care, where the radiologist might have mentioned the calcium or not in their report. The other half got a notification, so the patient and their primary care doctor got a notification that they had this calcium. There was a little picture of the calcium in there. And what we found is that in the patients who got that notification, their rate of statin use went from 7% up to 51%. So we had the chance to really save lives with this. This has now been licensed to a startup, and they used a subsequent multi-institutional study to get it cleared through our FDA, and it's now being sold in the United States. Okay, so that's just some examples. Extracting information that we don't normally extract, like that coronary calcium, or improving efficiency, like that reporting tool, for reducing the cost of devices like that nice image enhancement method. Now what I'd like to do is talk to you about language models and ChatGPT. So ChatGPT and language models are part of a class of models that we like to call foundation models. This was coined, the term was coined by my colleague Percy Lang at Stanford. And what we do with foundation models is on the left, we just take a large amount of data. So ChatGPT was trained on essentially the entire internet. And I'll talk about how that's done. It's using something called self-supervision. And then we create this foundation model that knows a lot about that particular area. We can do the same for medical images. And then we fine-tune it. We adapt it for a particular task. So ChatGPT is adapted for question answering. An imaging model might be adapted for image captioning, so we create a text description of the image, and so forth. So that's a foundation model. And so what I'd like to do now is to explain how ChatGPT was built and how we build systems like this in the lab. And I can use the name ChatGPT to tell you why that is, how it happens. So the G in ChatGPT stands for generative. And that means these models are built to, as opposed to the models we've been talking about where we might classify the image of, does it have pneumonia, does it have nodule, does it have calcification. Now we're actually generating new content, new information, new words. So it's just designed to probabilistically generate the best next word each time, a generative model. The G, it should be the P, that little red bar over under the P there, stands for pre-training. And that's the self-supervision method. So what we do is we ask the computer to play a game with itself. So it hides a word from itself, and then it tries to guess the missing word. So shortness of, okay, low grade, fever, elementary school, teacher, she appears hard, anxious. Okay, and so over same principle as before, guesses the word, whether it gets the word right or wrong. It changes the parameters a little bit to make it more likely to get the answer right the next time. And over many, many guesses, it gets to be really, really good at guessing what the next word should be. Lastly, the T stands for transformers. I'm not going to go into this. It's a complicated neural network architecture that works very well for this type of approach. Essentially what it does is it allows the prediction of the next word to be dependent on any of the words that have come before. And that's a very powerful tool that's relatively new based on this architecture. Okay, now the chat part. Okay, so now we have this foundation model that knows a lot about language. Now we're going to train it to be a chatbot. And this was really the revolution, and the people who did this didn't realize the effect that it was going to have. But this had a really profound effect on the performance. So what we do is we ask the model a question now. We say, what is the meaning of it? Okay? And it gives us several answers. These are probabilistic systems. And then we have humans rate the answers. Which is the best? What is their favorite? And this is called RLHF, reinforcement learning from human feedback. And in the course of this, these models get very good at answering questions in a way that humans find pleasing, very compelling. And in fact, ultimately what we do then is we train another AI model to emulate what human preferences are, and then we have those two AI models play with each other for a long time, and then we get this really nice performance. Okay, so what are the implications of this for healthcare? I want to tell you about a really interesting experiment that was done by research at the University of California, San Diego. There is a place on the internet, it's a site called Reddit, which has a bunch of discussion groups. One of the discussion groups is called Ask Doc, and patients can go there and ask questions, and then doctors can go there and answer the questions. And so they took some of these questions. Here's an example of a question the patient asked about going blind following bleach being splashed in their eye, and if you go blind, their eye is very irritated. And here's what the physician response came on this discussion board. It sounds like you'll be fine. You should flush the eye anytime you get a chemical or foreign body in the eye. You can also contact poison control. Now I'll give you the chatbot's explanation. I'm sorry to hear that you got bleach splashed in your eye. It's important to rinse the eye, so you get a much longer explanation. There's some empathy at the beginning. And then they asked a panel of expert physicians, blinded to whether it was the chatbot or the for the actual physicians to rate them for quality. And they found that the chatbot's explanations had a higher quality. And then they had the panel rate them for empathy, and they found the chatbot had higher empathy. Okay? And that, I think, is partly because these models are trained exactly to be very pleasing to humans and very empathetic. That's that RLHF that I told you about. It's a little unfair because these are not actual doctors with their own patients in their own clinic, and I understand that. But nevertheless, I think it tells us how compelling these systems can be. Okay, that's the good part. Here are some of the problems with these language models. We've all heard about the inherent limitations. So these models are limited by the training data. So if Taylor Swift gets a neuropathy, there's going to be a lot of talk about neuropathy on the web, and all of a sudden neuropathy might rise up in the differential of a chatbot that's trying to give a differential. So, and there are obviously discrimination, other issues that we need to think about in the data that's out there. Well-known hallucinations, confabulations, making things up. These models are probabilistic, and if something is 51% the next best word versus 49, it'll go ahead and guess that word even though it might not necessarily be correct. And then tasks like that require high-level reasoning, like planning or even mathematics, are difficult for these chatbots. There are some things that we're doing in the lab. There's something called retrieval augmented generation. So to combat these problems, RAG, what we do is we take a source that we trust, like a database or a website, and we say, please use this content to answer the question, but use your wonderful language skills. So it combines the language skills of the language model with the content that we trust. And then we spend a lot of time thinking about, and this is a hard problem in the lab, how do we know if we built a system to, let's say, summarize a radiology report, that it's better than the previous method? Well, we need to have ways of evaluating the quality. And sometimes we have to do human experiments, but we also try to think about scoring methods to decide when something's getting better. Okay, so how are these language models likely to affect the practice of medicine? I like to think about 3 different ways. So the first is small language models. So these are models that are built for a specific purpose. So we're going to, in the lab, build a model. Its sole purpose is to be very good at summarizing radiology reports. And it turns out when you do that, that accuracy of that model is going to be better than ChatGPT. Okay? Then you could just try to use ChatGPT or DeepSeek or any of these models right out of the box. And what that's going to do is for $20 a month, many hospitals, maybe Stanford, we have lots of capabilities in laboratories that can build these fit-for-purpose models. Many hospitals don't have that. But for $20 a month, they can get something like ChatGPT, which is pretty good at doing those kinds of language tasks. So that's going to democratize the use of AI. And then lastly, build our own. So I think we will have a moment where we will build models that are trained on high-quality medical data, just like ChatGPT is trained on the internet, large amounts of data, that will give some really interesting increases in performance. So now I want to show you an example of each of these 3 modes. So first, and this is a complicated slide, so I'm going to walk you through it. This is a small model that we built. This was in collaboration with Raj Prakar's lab at Harvard. So what we do is we take 2 neural networks, one of which encodes information from images, one of which encodes information from text. And we pass these 2 models pairs of images and text. Sometimes the image matches the text. It's the report that the radiologist dictated to describe that image. Sometimes it's a mismatch. And then we have a 3rd network that's designed to determine whether it's a match or a mismatch. Okay, so it's playing a game with itself. It's a different form of self-supervision. It's called contrastive learning. That's the training process. So through that process, we feed it many, many pairs. All 3 of these neural networks get really good at what they do. Now, we're going to use these networks. So we have a new image, never been seen by the system before. We use that purple box, that neural network, to encode the information from that image. We then have 2 prompts, a positive prompt, which is pneumonia is present, and a negative prompt, which is pneumonia is absent. We encode both of those using that network that we built to encode information from text. And then we use that 3rd network to score these 2 prompts, say which one better matches the encoded information from the image. So in this case, the negative front got the higher score, so we would say this chest x-ray has no evidence of pneumonia. So what we've just done is we built a neural network that works very well at classifying abnormalities on chest x-rays using just the information that's already available in our clinical system. We didn't have to have experts label anything or any other more sophisticated process. So that's our fit for purpose. Now I want to tell you about adapting these language models for patient purposes, and this dovetails with something that Kevin mentioned in his talk, which is the post-visit activities. So in the US, we have an act called the Cures Act, which says that patients must have immediate digital access to their test results. And I can tell you from my own family, when they receive their radiology reports, they have many, many questions. Okay? What is a mild intrasubstance degeneration in the posterior horn of the medial meniscus? Right? So we have many terms that these reports are designed for communication between two physicians who went to medical school, and the patients are often mystified by this. So we had previously built in the lab a technology that could extract concepts from text, from medical text. And so we extract these concepts, and then we pass those to ChatGPT, and we get these very nice explanations, like the medial meniscus is like a cushion that helps your knee move smoothly. Over time, it can get a little worn out. It's kind of like when your favorite pillow gets a little flat, but it still works fine. So really nice, analogy. So what this does is it really helps patients engage with their care. We can do it in their own language. We can do it at the right reading level, and we can help them be more engaged and understand their care plan. And then we looked at this, of course, we were worried about hallucinations, and so we had a whole panel of experts, myself, and I recruited 4 residents, and we rated hundreds of these explanations and found that none of them really had anything harmful that was hallucinated. Here are the 2 examples. There was one of the explanations said that the ventricle is part of the brain. I guess that's debatable. One of them said that if you put a tube in your right mainstem bronchus, it can help you breathe. That's a little low for most patients, but patients aren't going to be putting in their own ET tube anyway. So, okay. Another way we can adapt these models is, you may have heard that we've been talking so far about models where we pass it text and we get text back. There also are models where you can give it a prompt and it will create an image for you. Right? So we have Dolly is one of these. So show me a kangaroo with sunglasses in the style of Rembrandt. Show me a hamburger in the shape of a Rubik's Cube. Show me astronauts exploring a spacecraft. All of these are created automatically by AI. Some of my students said, I wonder what would happen if you asked this system to create a chest x-ray. This is what you get. You get kind of a cartoon, right? And so we thought, I wonder if we could actually adapt this, we could train it to be better. And so we trained the part that recognizes language on a bunch of radiology reports. We trained the diffusion model, which is the one that creates the images, on a bunch of chest x-ray images. And we found, in fact, that you can now, all of these images are created automatically by AI. So no finding, cardiomegaly, edema, all different kinds of findings. You create examples of those. So interesting implications for teaching, but also this can be used as a way of supplementing real data with synthetic data to improve the accuracy of the models that we train. Okay, lastly, I want to talk about the third way that was on the far right there, which is to train models on high quality medical data. And to illustrate the implications of that, I've here plotted the size of the largest training data set for the largest model inside medicine versus outside of medicine. So for text here, 82 billion tokens or words versus 15 trillion tokens or words. This is a log scale, so over 100 times greater size of the training data outside of medicine. Same for images. Major. So we have this massive data gap in medicine right now. We are not training on a very large data set relative to ChatGPT. But even the data from just a single health system, so I've plotted Stanford here, we can substantially close that gap. So I think we are getting close to a kind of a ChatGPT moment in medicine, where we are training on very large, high-quality medical data sets and we'll start to see performance improvements in the way that we saw this big leap when ChatGPT came out. And I don't think we're there yet, but we're just starting to see there are many companies and many laboratories working on training on these very, very large data sets now. This is just one example from my lab. So we trained on 6 million chest x-rays. And this is accuracy on the y-axis here relative to the other published models. You can see ours in red is much more accurate on a variety of tasks from disease classification to image text reasoning. So it's promising, and we're working on this. My colleague Akshay Chaudhary is working on CTs, same thing. And we're working up to the point where we're going to be training on our entire imaging archive. Oh, sorry, I put the slide in. This is my colleague's work. Akshay Chaudhary, our web labs have worked together on both of these projects, just showing that, again, in the orange and the green is the accuracy on detecting a wide variety of abnormalities on abdomen CT relative to the prior study. So really powerful methods. All right, so that's kind of a good review of these language models, foundation models, and how they may affect medicine. What I'd like to do now is just run through a number of the challenges that we face as we design, develop, and implement these systems. And we do have an initiative at Stanford called Raise Health. I'm pleased to be a part of the leadership of this. It's an initiative sponsored by the dean of our medical school and the head of our university-wide AI institute called the Human-Centered AI Institute. And the idea is to guide the responsible use and implementation of AI. So is it responsible? Is it fair? Is it safe? How do we think about those problems? I really like this publication in Annual Review of Biomedical Data Science that reviews the issues at each step of the way, from development, from bench to bedside for AI. And I want to take you through some examples from each step here. So first, let's talk about problem selection, data collection. And as I said, we're dependent on our training data, so we want to think very early on what data we want to collect based on the problem we want to solve. Make sure that we have the right real-world variability of the data, so our algorithm can have the right answer for all the different subgroups of patients. And it's important to recognize that our data is different. So ImageNet, which I told you about earlier, the images are 224 pixels by 224 pixels. If you prompted that model DALL-E that I told you about, it will give you an image. So here's a hippo in a lily pond in the style of Van Gogh. Gives you this image. It's 1024 by 1024, which is about the size of a CT scan. But of course, a CT is 100 slices, and that's just the pre-contrast, and then we have the during contrast, and then we have the post-contrast, and then we compare to the prior, and then we relate it to the other data, the electronic health record data, the medications, and all the other, the genomics, the wearables, the other forms of data. So bottom line, our data is far more complex actually than most types of data that AI is being used on and that research labs are studying. So it gives us just a very rich set of questions that we need to answer that aren't necessarily being answered in the wider AI research world. We have tried to do our part at Stanford in our research center to make data available. So we've now released over 20 AI-ready data sets, including 225,000 chest x-rays with their reports and all the demographic data, so we can do fairness analysis and so forth, and a whole variety of other data sets. I think that's very important, but it's really not enough. In 2020, we did this study where we looked at where is the training data coming from in the United States that's training all of these AI models, and found that the majority of it is coming from just 3 states. So we're probably not, given the issues of generalizability of these models, we're probably not getting a model, an algorithm that's getting the right answer for all the different patients across the country. And the same is true across the world. So this is my colleague Leo Celli, who at Harvard, who's done a similar analysis across different countries across the world. Most of the data is coming from just a small number of countries. One of the answers to that is something that we have I'm again fortunate to be in the leadership of this group called the Medical Imaging Data Resource Center. This is funded by our National Institutes of Health. It was originally funded for COVID. The idea was to bring together high-quality data on COVID. We gathered data intentionally from a variety of sites across the country, as you can see from that map. And as a result, the data set, and this is just one dimension of ethnicity and race, it mimics our census very closely. It's not inexpensive to do this, granted, but this has been very effective. We've now ingested over 500,000 chest x-rays and chest CTs for COVID patients, and have begun collecting data for other disease states like cancer. So that's data. Now let's talk about outcome definition. And to do that, I want to describe the first AI algorithm we ever built in our center. The application was bone age. So these are children who are suspected of having developmental delay. And what we do is we take an x-ray of their hand, and we compare it to an atlas called the Mulligan file. And we page through that atlas. All radiologists do this. We find an x-ray that pretty much is the same as the x-ray of this particular patient. If that is like 7.5-year-old, we say, okay, this patient is bone age, is 7.5 years. We thought this was a wonderful application for AI. My colleague David Larson led this work. And we found that it was very accurate. So here, lower bars are better, closer to the right answer. We found that it was a little better than 2 radiologists and about the same as 2 others. So human level performance. We looked at where is it looking. It's looking at the wrist bones, at the joints. That's the right place to be looking. We were very comfortable with that. And then we did a randomized trial. We showed, not randomized, a prospective trial. And we showed with almost 2,000 studies and nearly 100 radiologists that radiologists in general, when AI assistant was granted, again, closer to the right answer, which is to the left, radiologists are being helped by this algorithm. So you say, well, that sounds like a wonderful story. What's wrong with that story? Right? Well, that atlas that we're comparing to, the Mulligan file, was developed on 300 white children who grew up in Cleveland, Ohio in the 1950s. So we're not training to the right standard, and we do know there's good evidence in the literature that different groups of patients have bone development that happens in different ways. And so I think if we were doing this study today, we'd be much more intentional about the objective that we were training against and the type of data that we collect to make sure that we get the right answer for all the different groups of patients. Algorithm development, this is basically all of statistics. So there's so many ways in which these kinds of evaluations can go wrong. But I'll just show you one. So this was a nice study done out of New York where they were training an algorithm to detect pneumonia. And they collected data from 2 different hospitals. In one hospital on the left, they collected data that was mostly from ICU patients, portable chest x-rays. The hospital on the right, they collected data on outpatients. And then they trained the algorithm. The algorithm was performing very well. And then they used these heat maps to determine, to ask, like, where is the algorithm looking on the x-ray? And they found it's looking mostly at this little marker. It's describing what is the left side of the patient. And the 2 hospitals had different markers, as you can see there. And because the prevalence was so different in the ICU patients of pneumonia versus these outpatients, it was using that. So that's just one example of what statisticians, I think, would call it a confounder, but many ways in which these algorithms can go wrong. I don't have time to go through them all here, but just important to note that there's no magic about AI that's going to make all this stuff go away. You really do have to think carefully about all the same statistical considerations you do with any other kind of diagnostic technology. And then lastly, post-deployment considerations. So these algorithms are amazing. Right? When I was back in training in the 1980s, it took us 4 years at a PhD to develop an algorithm that could work on maybe 3 patients. Now, in a week, if I have the right training data, I can build an algorithm that works on any patient, and it's far more accurate than what I could build back then. But these algorithms are subject to data drift. So if you have a new device, we've even had a new version of software on a CT scanner can affect the accuracy of the algorithm that processes those CTs. Or if you have a new clinic that opens up with a different patient population, different demographic mix, or you have a new disease, So we had a pneumonia algorithm that was in a clinical trial across the western United States, and COVID came, and we had to completely retrain it because all of a sudden pneumonia looked different. As a result, our regulatory agency, the FDA, is considering, it's already given guidance on something called a predetermined change control plan. So the manufacturer of the algorithm can get it approved, and along with the approval of the algorithm, they get a change control plan approved that allows them to do that adaptation. So they built the algorithm, now they go into a specific setting and they want to fine tune it to make sure it works on the data in that hospital. And they can do so as long as the parameters are within their plan, it can be approved in that way. They don't have to go back through the regulatory process for each change that they make. Something that I think is way understudied is how these algorithms interact with humans. I think we need to learn a lot more about it. This study illustrates that. So this was a study about mammograms, and we have 3 different levels of expertise. So on the red, you can think of red as residents, blue as fellows, and gray is attending physicians. And on the left, those 3 bars are when the algorithm gives the right answer. You can see everyone does well. On the right, when the algorithm is incorrect, and you can see that particularly the inexperienced readers have their accuracy negatively affected. So we have humans who are inappropriately listening to the algorithm more than they should in this case. So we call this automation bias. This is just one example of ways in which we need to study how AI presents its information to humans to make sure this human-machine system is optimized. Again, just at the beginning of understanding that. The good news is, and this has been true since back when I started studying AI in the 1980s, that the combination of human and machine are better than either one alone. That's almost always the case. And I think it's because the machine is detecting a different set of things than the human. The machine looks at every pixel every time, sees all the corners of the images, can find things that humans sometimes might miss. On the other hand, humans have certain context and other information that can lead us to focus on areas of the image that are important and to dismiss things that we know are not important. So human plus machine is better than either one alone. I think that's a good principle to live by. I often get asked, will AI replace radiologists? Maybe you can talk more about this in the Q&A. I always say the answer is no, but radiologists who use AI will replace radiologists who don't. And I think the same is true for other, if you want to learn more about why I said that in this editorial, but I think the same is true for other professionals, actually other physician professionals, other clinicians, even outside of medicine. I think that's a good rule. But there are some exceptions, which perhaps we can talk about later, but I think generally we have a workforce shortage in radiology, and I think it's going to be very important for us to utilize these tools. So I hope I've given you some sense of kind of the opportunities and the challenges in implementing AI, and also started you thinking about how this might change the way that we educate physicians in the current moment. Thank you.
We have a few minutes for questions.
I'm Chairman from Dr. University. Thank you for your expert sharing our amazing AI radiology. With the advance of AI, the landscape of medical education is being dramatic. Now students can acquire knowledge, skill, even attitude, as you mentioned, from the AI. Doctors are increasingly relying on AI for diagnosis and treatment. But with a shifting paradigm, how teachers should adapt their approach to teaching in the future of medicine and the medical education. We recognize that we need amazing AI in radiology, but do you think we also need AI as a medical teacher?
Yeah. I think back to when I was a medical student, we had, I think, 1 or 2 actors who would pretend to be patients and have a chance to interview the patients. But nowadays, I think a language model could pretend, you could ask the model to pretend to be a patient with thousands of different diseases, and the student could interview many different patients, and even the language model at the end of that interview probably could give feedback to the student about where they could do better, what they could do differently. So I think that's just one area where these technologies can improve the way that we teach. I think the other issue that we will face is the same issue I suppose we face with elementary school children learning arithmetic. So we wouldn't want a third grader to have a calculator if they're filling out their multiplication tables. Right? We don't want a resident on day one to have a tool that's going to create the report for them automatically. I think the resident needs to create their own reports for a period of time. On the other hand, there's a point at which maybe you're majoring in chemistry in your post-secondary education, your college, your university, and when you are in the real world, you're going to need to have a calculator. And so you can do your chemistry problems with a calculator. And so where that transition point happens, I think, is a very interesting question. When should we let trainees start to use some of these powerful tools, and when should they still learn to do some of it on their own? I still think there's an issue, and it's been alluded to in some of the earlier talks, that over time, even now more experienced physicians may lose, again, some of those skills. Just like, could I do long division today? Probably not, because I haven't done it since the second grade. So dealing with all those issues, I think, will be very important.
Thank you very much for your excellent talk. I am most intrigued by your discussion about the challenges of AI. Just two questions. Number one is, given in medical field there are so many specializations, should we focus on small language instead of large language model for our specific purposes? And secondly, you mentioned also what is developed in the West may not be applicable or be accurate to be used in the East. So how do you think we should all be developing our own algorithm for our own region or even our own city?
Yeah. Thank you. That's an excellent question. I think the way that this is going to end up, we're not there yet, is that we will build a series of foundation models on high quality healthcare data. I don't know whether you want to call this small or large, but it's going to be a large amount of healthcare data, and that can serve as a foundation model. So for radiology, we may not have just one. Maybe we'll have foundation models for 3D imaging, 2D imaging, perhaps different body regions, maybe a small group of foundation models. And those probably initially will be trained on the data ours will be trained on Stanford data. Then that model can be used as a foundation for a downstream model. So let's take a pneumonia model or a nodule model. Because the purpose of that foundation model is to reduce the need for training data and improve the accuracy of that downstream model. So we can now train on a small amount of data from wherever around the world. So anywhere around the world, or a small amount of data for a rare disease that enables us to deliver that model and tailor it to that local situation much more easily because it already knows a lot about that, whether it's imaging or some other domain. So I think that's likely the way that the future is headed, is with these foundation models as a foundation, and then using that kind of various fine-tuning methods on small amounts of data from local circumstances to make the model applicable in those areas. Now, what you'd like ultimately is for that foundation model to include data from all around the world, right? So that it would really work even well anywhere. But I still think even a foundation model developed at Stanford, let's say, might still work well in Taiwan if it was fine-tuned on data from Taiwan. So that to me would be the first step. And then as we get better and better at developing these larger and larger models, let's see if we can pool data from multiple locations.
I do want to comment that the National Health Insurance has imaging of all the patients, 23 million in Taiwan, and also there's a collaboratory right now between university to augment the medical records. And so, maybe there's a way to contribute to the data gap that you mentioned through a federated model that you mentioned.
Yeah, federation is another way to do that, and I'm envious of that, and is a real opportunity, I think, for you to lead the way in developing that for your own area.
Just click on that. Red is on.
Do you hear me?
Yes.
Yes. Thank you, Professor Langtloz, for your very nice talk. I'm Chuan Chai from China National University, Taiwan. I'm a neurologist, so in our department we did develop a kind of AI for the non-conscious CT for the prediction for the lung vessel occlusion in stroke patient. But one thing we encounter is that when we struggle for this problem for 2 years, that the accuracy of the prediction model is near about 80% accuracy. So in this condition, we did some improvement. So for example, we asked for a group, they can do the green AI learning for the improvement of the problem. But as I know, there are some kind of techniques, for example, to improve the original CT scan for further training of the AI model. So do you have any kind of suggestion before we do the training for the AI model? Do you have any suggestion to improve the original imaging technique?
Yeah. Models trained on high quality data will be more accurate. The trade-off there is that in the real world, not all data is high quality. So your model may not apply to as many cases if you train it on this very, very high quality data. But I think you will improve the accuracy if you train it on data on images that are of higher quality. One of the things that people are starting to do is using, I don't really love this word, but agentic. So we have multiple models. The first model says, is this imaging of high enough quality that I am going to be accurate in determining whether there's a nodule present or not? And then, so a certain percentage will not be processed by the AI, and then AI is used only for those cases where you know that it will be effective. If you improve the quality of your images, you would think then you have more data coming to the AI, and the AI would be more accurate.
I think we're running out of time.